right, we're going to get started. Good evening, everyone, and welcome to the 6th Mini Medical School of 2021. My name is Brett Hope, and I'm a first-year student at IU School of Medicine, and I'll be your moderator for tonight's session. Unfortunately, this year our format is a little bit different, and we're having to hold it over Zoom, but thank you for coming with us virtually tonight. Before I introduce you to our panelists, I'm going to take a moment to thank the sponsors who have made our 26th annual Mini Medical School Series possible. Thank you to Hamilton Center, Inc., ISU, Indiana University School of Medicine, Lugar Center for Rural Health, Minority Health Coalition of Vigo County, Terre Haute Regional Hospital, Tribune Star, Union Health, Via Media, West Central Indiana AHEC, and WTHI TV. And lastly, I'm going to explain the logistics for tonight's event. So our Zoom webinar platform is going to allow us to feature our local expert panelists. All other attendees will be muted during her presentation. I encourage you to submit your questions during the presentation using the Q&A button located at the bottom of your screen, and your questions will be answered by our panelists after a brief intermission after her presentation. And tonight's topic is going to focus on GI health. Without further ado, I'd like to introduce you to our panelist, Dr. Rebecca Lynch. She is a practicing general surgeon in Terre Haute, Indiana, and she went to the University of Michigan for her undergrad. She went to Wayne State University for medical school and did her surgery residency in Akron, Ohio at Summa Health. She grew up in Terre Haute and returned in 2015 to join her father, Mark Lynch's surgery practice. Currently, Rebecca and her two brothers, Brandon and Nicholas, practice together with their father. As general surgeons, they have a broad range of surgical expertise, including surgery of the GI tract and endoscopy and colonoscopies. Without further ado, Dr. Lynch, please take it away.
Hi, everyone. I wish I could see you. Sorry, this has to be on Zoom, but I'm here to talk to you about GI health. I'd like you to ask me any questions you have, and I'll try to hit all of those points at the end of the presentation. So, and bear with me, I haven't done a Zoom presentation actually before. Many Zoom meetings, but not a presentation yet. So, okay. Let me just get this. Okay, so here's a picture of basic GI tract anatomy. So when you talk about the GI tract, you generally describe it as the upper GI tract and the lower GI tract. You may have heard these terms before. In general, when we're talking about the upper GI tract, for example, if you hear someone saying, I had an upper GI bleed, it's usually a bleed that happened in the esophagus or the stomach or the duodenum. These are areas that I'll go further into detail, but that usually forms the upper GI tract. So it's kind of this area here. I'm trying to circle with the laser. The lower GI tract really encompasses the remainder of the small bowel and the colon and the rectum. Your liver, your gallbladder, and your pancreas, so liver, gallbladder, bile ducts, pancreas, those are all also very important structures that really help with digestion as well. And so I'm going to touch on those briefly as well, since they are an important part of our GI system, okay? Here's a picture of the bowel. And I put this picture here to really show you what our GI tract's main function is. So you intake food, you excrete waste. The middle process of digestion is the really complex, important part of why we eat, why we have a GI tract. This is an example of the jejunum, and this is a slide taken from a pathology image. This is cut under a microscope, and this is looking at the specific cells in the jejunum, and you can see it looks like a shag rug carpet. All of these fronds make a really nice broad surface area so that there is a lot of surface area for absorption to take place. So our GI tract has very specialized cells that are different along the entire GI tract to make sure that each area can do its job. The GI tract also absorbs a lot of water. So this is where we have some water regulation, nutrient, vitamin absorption, and then waste excretion. Okay. So I'm going to go through just the basic areas of the GI tract and give you little tidbits about all of them. And then we're going to talk about problems that happen in the GI tract, and we'll kind of talk about how we solve some of those problems. So first, start with your mouth. Digestion actually does start occurring in your mouth. As you chew, you are breaking down, you're really breaking down the food. You have amylase, which is an enzyme in your saliva. This also comes from your pancreas as well, but there's a little bit in the saliva, and that starts to break down the food products. Once you have a food bolus that is pushed back into your esophagus, and the epiglottis really helps to protect your airway, which is the trachea, so that when you swallow, the food actually goes down the right tube instead of the wrong tube, because we don't want food in your lungs. The esophagus is really like a nice, thick, muscular pipe. And it's not a pipe that just sits there and does nothing. This pipe actually peristalsis, so it has this wave of muscular contraction. If you look in this picture, you can see that this will propel the food down the esophagus. So technically, if I was laying down or standing on my head, my esophagus should still be able to propel food somewhat into my stomach, okay? And that's when it's working normally. Sometimes it doesn't always work normally, and we'll talk about that soon. The stomach is also a very muscular structure. It really churns the food, as well as it has a lot of acid in it. This acid, as well as further enzymes, help to break down the food, kill off some bacteria and viruses, and allows that food to appropriately enter the small bowel for digestion. There's a very important sphincter in your stomach right here, and this is called the pylorus. That pylorus allows the food to enter the duodenum slowly so that you don't have a rush of food into your bowels all at once. Now, these bowels down here, they really do the majority of the absorbing. So if you were to suddenly absorb too much, if you don't have a pylorus, that could make you sick. And so that's why the pylorus is so important. The small bowel absorbs the majority of your water. The jejunum really is kind of the powerhouse absorber, but the entire small bowel, you're going to be absorbing nutrients, vitamins, whatnot, okay? Now, if you look at the duodenum a little closer here, you notice that there are these blue ducts that go there, as well as you can see the pancreas here, and that has a blue duct. All of these blue ducts contain either bile and or the pancreatic juices when the pancreas duct connects, and that aids the process of digesting by mixing with all of those substances as well, okay? So the pancreas, the gallbladder, and the liver don't do any absorbing, but they help give the GI tract the tools they need to allow the bowels to absorb what they need to. The bile is really made in the liver, okay? This bile travels down this bile highway, and then when it's not needed, it gets stored in the gallbladder. Now, sometimes the composition of the bile is off for whatever reason, and when that happens, you can make stones in your gallbladder, and we'll kind of talk about gallbladder disease later, but there's a few things that can happen with your gallbladder and make it not work. When you eat a fatty or greasy meal, that gallbladder is stimulated and the bile comes out, and it travels down the rest of the bile highway, and then eventually goes back into your bowels so that it can help you absorb fatty substances. The pancreas has further enzymes for digestion. It also is very important for insulin regulation as well, for example. And it has many other functions, but mainly it will give you these digestive juices through these bile ducts where it mixes with the bowel and helps you to digest. As we go through the small bowel, you'll enter into the colon, okay? So the small bowel will enter into the colon here. This is the ileocecal valve, okay? The cecum is the beginning part of your colon. You may hear that term when you have a colonoscopy. The appendix sits off of the cecum as well. Now, the colon's job is to absorb some water also. It really also has a lot of bacteria in it, and those bacteria further will help break down what is remaining of the food. And then it can also synthesize some vitamins through the bacteria. This is where the gas is formed. And then as the stool comes and travels along down here to the rectum, it gets more and more dehydrated, and that's why your stool is generally not liquid, because the colon absorbs that remaining 10% of water, and then the rectum has a sphincter that allows control. And there's actually a sampling process here so that your body knows whether it's gas or whether it's actual solid stool. And then that's what gives us our continence. Okay. So how do we keep our GI tract healthy? There are a lot of diets out there. A lot of these diets are not good diets, in my opinion. You really need carbs, you really need fat, you really need protein. Having a diet that has 0 fat in it is very hard to do. It's not healthy. Having a diet with 0 carbs, that's also not healthy. So when people ask me, how can I be healthier? I just say, you really got to go back to your basics, what they teach you in school as a kid. It's all about proportions, and it's all about having a balance. So you don't want a giant plate of just broccoli and eat that 3 times a day. You also don't want a giant bowl of ice cream 3 times a day. That is the carb-free ice cream. That's still not healthy. So you want a nice mix of all of these substances. And when you do that, that is healthier for your colon, because your colon actually needs all of these substances, and your GI tract needs these substances to do well. You need to have some fiber in your diet. You need to drink water. Most adults at an average weight need to drink at least 8 glasses of 8 ounces of water. If you don't drink that much water, then you could be dehydrated. Some people can even have significant constipation if they're not getting enough liquids, and it can also hurt your kidneys and other organ systems. Smoking has been found to be related to colon polyps, and that is also related to colon cancer. This can also be related to other cancers of the GI tract. So nicotine is really a big no when you want to keep your GI tract healthy. Exercise is very good for good gut function, good well-being. A lot of stress boosts your cortisol, which boosts your acid, and then you're talking about stomach ulcers, gastritis, those sorts of things. And so it's interesting, but everything that we do really does affect our GI tract in some way or another. The last thing that I think is really important that I'm going to emphasize during this talk is screening for cancer. There are very specific screening guidelines that are continuously updated, and I'll share those with you as we continue. Okay. So how do we know there's a problem? I listed a lot of examples of problems. There, of course, are more, but if you have pain, if you have bleeding, if your stool is normally brown and it suddenly becomes dark like tar and it looks completely different, that's a problem. If your stool is normally a normal caliber and then it becomes pencil thin and it's like that for a month, that's a problem. You need to let your physician know, because this is something that you'll need to be evaluated. So all of these symptoms I would bring up to your physician if you have them, okay? So I'm going to go through each of the areas. So we'll start with the upper GI tract, and I'm just going to discuss a few really common problems in these areas. So here are some of the common problems that I see patients for: reflux disease, hiatal hernias. Esophageal dysmotility means a problem with the esophagus contracting and peristalsing. So people are not able to appropriately swallow their food or get their food to the stomach appropriately. You can have gastritis, peptic ulcers, as well as cancer in the upper GI tract. There are more diseases, but we'll start with these. So I just wanted to show you a number of pictures. So this is your stomach, here's your esophagus, and here's your duodenum. There's a diaphragm muscle here that separates our chest and our abdomen. When you eat food, you want the food to come through, stay in your stomach, and we don't want it to go back up. When it goes back up, that's what reflux is. Some people feel pain. A lot of people, they'll feel a burning that comes up, sometimes to the back of their throat. Sometimes it's only down lower. That area is called your epigastric area. That's a medical term for your upper stomach area. And so this is kind of a good example of what reflux looks like. Now, if you have a weakness here, okay, so there's kind of a pseudo sphincter at the bottom of the esophagus that is held slightly tight, and then it relaxes when food passes, and then it becomes tight again. Now, some people, their sphincter mechanism is messed up. People who have a hernia, for example, that's in this picture, their sphincter is not supported by their diaphragm anymore. So a hernia is a weakness. And so this area shouldn't be this big here. And so now some of the stomach has slid into the chest. And so this sphincter is displaced from its supporting muscle here. And people with hiatal hernias do not always have reflux, but they're more likely to. This is an example of something called achalasia. Now this patient, their sphincter is tight and it's not relaxing. It's really tight. And so the esophagus has gotten stretched out and large. And you can see on here, this is an X-ray where a patient swallowed a barium contrast material. And all of that contrast is really sitting in the esophagus and it's not promptly getting evacuated like it should. So problems with your esophagus and stomach can happen and are very frequent. Here's an example of one of the diagnostic tools we use to be able to look at the esophagus and stomach. So in this picture, you saw an X-ray study where the patient swallowed contrast and we took pictures. In this picture, now we're looking at an EGD scope. So EGD stands for Esophagogastroduodenoscopy because it looks at your esophagus, your stomach, which is the gastro part, and part of your duodenum. This scope is hooked up to a light source as well as a CO2 or air source. If you come in for an endoscopy, that is one of the endoscopy procedures. That's called the EGD. You will, so let's say that you come in for a procedure, you will be laid on your left side on the cart. There is a screen over to the side that the surgeon or the GI doctor can look at, and they will insert this scope down into your mouth, down into your throat, the oropharynx, and then down into your esophagus, and they can look at your esophagus and your stomach on the scope. I now have some pictures of what you look like on the inside when the scope is put down. So here's an example of an ulcer. It is friable, okay, so it bleeds easily, it's angry, there's a hole here, okay. This is an irritated ulcer. You don't want that. That can hurt. It's very painful sometimes when you eat when you have ulcers. Ulcers can also bleed, and some ulcers can go so deep that they burst a hole through your stomach or duodenum, and you need emergency surgery, okay? So this is a problem you definitely don't want to get, but it's extremely common. This scope picture is showing the stomach, and this is gastritis. This patient's stomach is red, kind of more bumpy, irritated looking. That's not what the stomach should look like. Luckily, nowadays, we have some very good medicine that can treat peptic ulcers as well as gastritis. And this usually doesn't need surgery. So usually we don't have to operate on ulcers, but we do sometimes if they pop or if they don't heal despite aggressively treating the patient with medicines. I will say it's very hard to get rid of ulcers if you're smoking. Nicotine decreases the amount of oxygen that gets delivered to your tissues. It interferes with your healing process because of its issue with oxygen. And so it's very hard to heal ulcers if you are smoking heavily. So that's just something to keep in mind if you have a problem like this, or if you have a friend or family member with that. Now, here's a really scary picture. I do not like seeing this, but here's an EGD and showing the inside of a patient's esophagus. This is what cancer can look like. This is very angry. It's causing bleeding. It's causing narrowing of the esophagus. We really don't want to see this. Esophageal cancer as well as stomach cancer are very real, very angry cancers, and they're usually, when they're found at a stage that is not really early. And not always, but oftentimes they're found when they're later stage, and that can be very life-threatening to the patient, and the prognosis, meaning the outcome, is not as good in patients with esophageal cancer in general as someone with a very early colon cancer, for example. So if you have really dark stools, if you have major reflux problems or upper belly pain, these are all reasons to seek medical attention. You probably don't have this, but it's something we definitely want to rule out if you have symptoms or problems. We'll kind of move down to the liver and the gallbladder as well as the pancreas now. I'm going to mainly focus here on the gallbladder because that's something that is extremely common. But outside of gallbladder disease, we have a lot of liver disease problems. Hep B and Hep C have been one of the leading causes of liver disease historically, but they are getting surpassed by fatty liver disease. We're not 100% sure what causes fatty liver disease. There's probably a genetic component. There's most definitely a component related to obesity and the lifestyle that we live compared to some other countries, as well as historically in the past compared to how people used to live. They do have studies where patients have gastric bypass surgery, and when they lose weight, over half of them, their fatty liver does improve. So we think that there is some relation to weight there. But some people are very thin and they eat healthy and they have fatty liver. So it's not all explained just by obesity, for example. Alcohol-induced liver disease is a preventable thing, but is very serious. It can affect you and be reversible initially, and then as time goes on, if your liver gets cirrhotic, that is more end-stage liver disease, and at that point it is not reversible. So it's very important to let your physician know if you have any of these medical issues, because those are things we want to work on so that your disease doesn't progress. Pancreatitis is a very common problem as well. It can range from very, very mild, barely even need to go to the hospital, have a little pain, goes away, versus it can kill you. It can be a very scary process when you have bad pancreatitis. The two most common causes of pancreatitis in the US are gallstones as well as alcohol-induced pancreatitis. Now, the gallbladder, here's a picture surgically. The gallbladder is the culprit for a lot of things. It gives you gallbladder attacks. It can give you pancreatitis. It causes pain, usually on your right side. If you look at this diagram of this person, this is his left side. This is his right side. Here's the liver. Here's the gallbladder. These are laparoscopic instruments, and this is kind of our setup to take out the gallbladder. Taking out a gallbladder is very common. Patients usually come in, they get this removed laparoscopically, go home the same day. Recovery, the first week, you're pretty sore, but usually very manageable with pain medicine for the first few days. And then the second week, third week, every week you get better. You don't want to let your gallbladder get bad. If you have a gallbladder problem, you want to have it done laparoscopically and go home the same day. If the gallbladder sits there and gets worse and worse diseased, yes, it can die, which we call a gangrenous gallbladder. It can be filled with pus and mucus and not be able to drain properly. It's something that you definitely want to make sure that you take care of while it's more easily treated. Otherwise, you may end up with an open surgery, or you may end up in the hospital for days with drains and other issues because it got extremely rotten. Okay, so this is something that we can easily take care of before it becomes a big problem. This is an example of a gallbladder that's really not too bad, but it is still inflamed and irritated. These are clips that we place on the duct of the gallbladder, and then we peel the gallbladder off the liver here with a special cautery device. And then we remove it from your belly and then send it to the lab for further testing. Gallbladder cancer is extremely rare. Yes, I have had a patient with gallbladder cancer, but I've taken out hundreds of gallbladders, and I've only personally taken out one gallbladder with cancer, and it's that rare. So our concern for the gallbladder is more of the problems it gives, not as much cancer. It can be cancerous, but it's very uncommon. So now we'll move down to the lower GI tract. I really wanted to focus a lot here on colon cancer screening as well as colon polyps, but there are a lot of other things that I'm going to show you some pictures of that can be problems in your lower GI tract. Diverticulosis, appendicitis, inflammatory bowel disease, that's Crohn's and ulcer colitis. You can have other causes of colitis like ischemic colitis and infectious colitis that we'll talk about. And then I put these on here as well: hemorrhoids, anal fissures, fistula abscesses. There are a lot of problems that can go on in your rectum and anal canal as well too. So colorectal screening is very important. Colon cancer is the third most common cancer in the entire United States, but it is the second leading cause of cancer-related deaths in the US. So this is a big, big, big area. There are about almost 150,000 new cases of colon cancer diagnosed in the US every year. So this is somewhere where we really want to focus on treating patients, getting them screened, capturing as many patients as we can with these educational sessions, because this is something that we may be able to intervene on earlier and save a lot of lives. There are a lot of options for screening. Colonoscopy is one of the screening methods that you would see me for as a surgeon, or sigmoidoscopy. Sigmoidoscopy is not generally done in the US just for screening. We usually do colonoscopy as the preferred method over a sigmoidoscopy. A sigmoidoscopy is only a partial scope, but there are some patients where sigmoidoscopy may be indicated instead. The other options for screening are imaging, such as a CT colonoscopy, barium enema, or stool-based tests. There are tests that can detect DNA that is shed in your colon from polyps and from cancer, as well as the stool test can detect blood, and that can be an indication of cancer. If you remember that picture of that esophagus cancer I showed you, you saw it was really raw. So cancers often bleed, and so testing the blood sample, the stool for blood, is a good way to just get an immediate response of, is there blood there or is there not? If there's blood there, you definitely need a colonoscopy, and that's not really screening at that point, that's diagnostic. The timing and the interval of when each person should have their colonoscopy is extremely individual based. It's going to depend a lot on your family history. It's going to depend on your personal history. And it's going to depend on if you have any symptoms. If you have symptoms, you need a diagnostic colonoscopy, not just a screening test, okay? The goal of any screening test is to find something early before it causes a major problem that is not reversible. And so our goals in colonoscopy are twofold. One is to detect cancer early so we can intervene before it is so advanced that it is more lethal. The second goal of colonoscopy is to find polyps that are risky to become cancer down the road and get rid of them. Polyps usually will form and are friendly, sometimes for years, sometimes not for that long, but a lot of polyps are friendly for years, and then they start mutating and becoming cancer. There are many different types of polyps, and I'm going to show you a couple pictures of polyps on our next slides, but we really want to find these and get rid of these. This is really important. The colonoscopy guidelines from the American Cancer Society were recently changed, and that was in 2018. They changed the screening age from 50 to 45. The American Society for Gastroenterology agrees with this 45 age range, and they say we suggest colonoscopy, you know, for screening at age 50, most definitely, but we also suggest that at age 45, you should be talking to your physician about screening, and it's very reasonable to start screening at age 45. Why did they lower the age? Well, it's because the incidence of colon cancer in older patients has actually gone down every year since 1980s, I believe. It's been decreasing and decreasing. However, in younger patients, such as those in that 45, 50 age group, their incidence of colon cancer, we have found, is increasing, and that's scary. Now we're seeing younger people with these cancers, and so that's why we have changed the age range to 45. Now, if you have a personal history of a genetic predisposition that makes you higher risk for colon cancer, you would not fit this average guideline screening potentially. You may need a colonoscopy even earlier. Patients who have other colon diseases, they may need to be screened earlier. And then patients with family history of significant dangerous polyps at young ages, as well as patients with family members who were diagnosed with cancer, especially at young ages, they may need to have colonoscopies at an earlier age. And so the newer guidelines were even updated last month in March during colon cancer awareness month. So that's very important. This is a picture. I find this picture slightly amusing, slightly interesting, but this picture is how they used to do colonoscopies. I did not train doing colonoscopies like this, but I have done sigmoidoscopies like this in the emergency room for someone who had a twisted colon. That's how we used to do that when I was in training. Now we use the regular scope, but they used to do your entire colonoscopy where the doctor would put their eye on the camera, and the camera would go in your backside, and their head would be right there, and they would blow up your colon with a little air valve, kind of like a blood pressure cuff, and it would blow up your colon. They'd take a look. Well, colonoscopy has gotten way more advanced since then. The patient will lay on their left side. Everything will get hooked up to a monitor, so you don't have to have your head down there to see. You actually have it on a nice big screen. This really magnifies our view. We have really nice images, and we inflate the colon, so it insufflates with CO2 gas, which is easily kind of absorbed and gotten rid of by your body. And so it's a more comfortable procedure than it used to be, okay? I thought it would be good to go through what to expect at your colonoscopy, because all of us at some point will probably have this procedure. So pre-procedure, you're going to be talking with your physician, deciding on is a colonoscopy right for you. They will order a prep, you know, based on what their standard prep is, and also based on what your clinical status is. Usually you have to change your diet at least one day ahead of time. Some people will do a 2-day diet change, but the day ahead of time, you're generally on a liquid diet. That's so everything can flush out, and so we don't see a bunch of seeds and particulate matter in your colon. The evening before you have your colonoscopy, you're going to start your bowel prep. There are some pill preps, there are some liquid preps, there's all different sorts, but you generally start them in the evening. Some split prep patients, you will get some prep in the evening, and then you'll wake up really early in the morning, and you'll take your additional prep before you go in to ensure you're fully cleaned out. The goal is to be able to see through your stool. It may be yellow tinged or brown tinged, but if it's clear and see-through, kind of like Sprite, that's the goal, okay? Having solid chunks in your stool after you've gone through your whole prep, you might not have had the best clean out, and that may limit our view. So what to expect when you get there? So you usually get there early. When you get there, the nurses will check you in. You generally get an IV that goes in your vein. You get connected to some fluids. You'll change into a patient gown. Generally, your physician, your anesthesia provider, if you're having anesthesia get you drowsy during the procedure, and your nurse, they'll all meet you. You'll then be wheeled back to the endoscopy suite. This all you may remember because you won't be asleep yet. They'll lay you on your side, kind of tell you what we're doing. And then if you're getting anesthesia, that's when you'll have all your vital signs measured. They'll be very closely monitored, and then you'll get that drowsy medicine. If you do MAC anesthesia, that's where the anesthetist kind of gets you comfortable during the procedure. You generally don't even remember the procedure. I have done awake colonoscopies on patients who wanted to be awake as well. That is a little more uncomfortable just because of the gas that we put in. It does distend your colon, and sometimes that is uncomfortable. But for patients who get some drowsy medicine, it's generally a very comfortable procedure now. Then the procedure is performed. After the procedure, you will awake. People are waking up pretty quick after this medicine, but you do feel drowsy sometimes for the rest of the day. You shouldn't drive that day. You shouldn't go into work right after your colonoscopy. You shouldn't do anything important because you'll still have that anesthesia medicine lagging. Most people that have some gas and some bloating, you will pass some gas. That's totally normal. And then you'll feel pretty back to normal quite quickly. Go home, and by the next day, you're kind of back to normal, almost like you didn't know you even had the procedure. There are a few people who will have some really angry polyps. They could bleed. They may have other issues, but that's not the norm. So how is it done when you're in the procedure? So we kind of looked at that picture where you're laying on your side. The physician will do your rectal exam, then they'll place the scope in through your anus, and it will be navigated through your colon. Well, here's a good picture of how these scopes look, okay? So here's a colonoscope. This is a smaller EGD scope, but in this colonoscopy scope, there's a port, a little channel that I can actually put a forceps through, or even a lasso to lasso out polyps so that I can sample things in your colon. There's also, this works as a suction channel. There is a light, so you see the lights on the side, as well as a channel that allows the air to go in. So we're capturing video, we have lighting, we have a working port to sample, and then we have a little port that puts in some air, okay? And we can push fluid through there too to wash out the colon if it has a lot of stool. All stool can't be washed out. That's why we really need a good prep. And then that's how we look at it on the monitor. Here are some examples of polyps. This is probably a very friendly polyp. This is a flat polyp, but it doesn't look that irregular compared to this polyp. You look at this polyp, it's pretty irregular. None of these polyps really look like cancer, but if we left this big ugly guy in here for forever, could it become cancer down the road? Maybe, and who knows when, okay? Usually it takes years, but it's really hard to say. Some cancers develop very rapidly. You can also have some polyps that look like this flat polyp that are angrier flat polyps that are very difficult to see, that can be hiding under stool. And those polyps could develop into cancer as well. And those would be hidden if your prep's not perfect. And so that's the biggest limitation of colonoscopy, is it's only as good as the prep and how the colon looks during the colonoscopy. Here's an example of a lasso taking out the polyp. This one is hooked up to a cautery device, and that cautery cauterizes the base. Here's the polyp detached, and then we suction the polyp through the channel. I retrieve it, and I send that jar to the lab, and then the lab will test it and see what type of polyp it is, okay? This big polyp has slightly a broader stalk. That bleeds, and so we can put a clip in and clip that polyp. So there are actually a lot of tools we use. Here's another polyp as well. Okay, so a lot of tools we use to sample lesions as well as to get rid of them. And none of this involves an incision. So there are no cuts on your abdomen during this. This is all done through your backside. Here's what we don't want to see during a colonoscopy. This is an example of colon cancer. So you can see that now, instead of just seeing a polyp that has its own defined borders, this is really irregular. It's irregular, it's extending, it's partially blocking this canal. It's what we call fungating angry. Here's another example of a colon cancer. And the problem with these cancers is when colon cancer becomes significant like this, you're often talking about doing surgery, potentially chemo, and if it's in the rectum, sometimes radiation. So you could go from needing a little snare, lasso like this, versus needing this surgery. And that's why we really push screening tests, because if you don't want a colonoscopy, there are other options, like we said, about screening tests. I think there's a lot of good things about colonoscopy. That's why I do them. But there are other screening tests. I encourage everyone to get the appropriate screening test for them, because it is necessary to help prevent things like this. Okay. I'll go now into some other colon disorders. These are other things that we can see on the scope. These are pockets. So these are different than polyps. Polyps are growths. A diverticulosis pocket is an area of weakness where some of this colon is bulged out, kind of like a weak area in a balloon. When you see that clown that makes the balloons for the kids at the fair, and they pull on an area to make it weak, to make the nose for the dog or whatever animal they're making, that's kind of like a diverticuli. They're just these weak areas. Now, a lot of people have these and they don't cause any problems, but they can get inflamed. And when they get really angry and inflamed, you can get diverticulitis. And diverticulitis, the itis part means inflammation. That can show up like this patient on the CAT scan, where now you have air and all of this irritation, inflammation where you're not supposed to have it. So this CAT scan is a patient who's laying down. This is their pelvic bones. This is their abdomen. This is their rectus muscle. Okay, this is their back side. And this is their left side. And here's their right side. And here is their sigmoid colon, and it's thick. None of this should be thick. This sigmoid colon is thick. This is just one cut. So this is just how we see that bowel here, but it's all thick. And this diverticuli has perforated, meaning busted. And now there's air and probably a little poop and some bacteria here. It's not supposed to be there in the abdomen. This person likely will either need a drain or surgery, depending on what they look like. Okay, so that's when diverticulitis occurs and gets really bad. There are other things that can cause you colitis. So colitis just means colon inflammation. So this is diverticulitis. This is ischemic colitis. You can see on both these pictures, these almost look like the ulcers that I showed you in the duodenum earlier, okay? Because ulcers can happen in your duodenum, they can happen in your stomach, but you also can get ischemic colitis where your colon does not get enough blood flow, and then it starts to almost die on the inside. This is the mucosa lining that's really kind of sloughing, dying, irritated, okay? So that's ischemic colitis. There's also infectious colitis. So E. coli infection can give you colitis. C. diff can give you colitis. And this is that pseudomembranous C. diff colitis, and it has a very classic picture. You definitely don't want that either, okay? Another itis that we often hear about is appendicitis. So that means your appendix is getting inflamed. So here's your rectum. We're traveling backwards up your colon here. Here's the beginning of your colon. Here's where the small bowel takes off. Here's where your appendix is. You don't really need your appendix. It's put there for us to take out, I guess, but you don't need it. It probably gets blocked by either some mucus or stool, and then when it gets blocked, it gets inflamed. This is an example of an angry, inflamed appendix. This appendix has actually perforated, or ruptured is another word you would hear. And when that happens, you can get a lot of pus and inflammation in the abdomen. So if you're hurting on your right lower side, that may be appendicitis. Appendicitis usually starts out with more vague pain as the appendix is getting swollen. Our body cannot sense that pain properly. It just senses something's wrong. And when the appendix gets really bad and inflamed, it starts touching our abdominal wall, and that's where we start having significant pain on the right side. So that's kind of the classic presentation of appendicitis. Some people have a fever. A lot of people don't want to eat anymore. They just don't feel well. And then the pain starts increasing over time. For this scenario, you generally have to have surgery to remove your appendix. Some very early appendicitis, they're treating in Europe with antibiotics. Sometimes we treat patients here with antibiotics before rushing into surgery. That's kind of a thing that's been debated. So that's just something, a pearl for you to know, something that's slightly different in the US and Europe, and just kind of depends on the exact patient's presentation on what's safe and reasonable. I just put this kind of disclaimer in because I'm giving a lot of medical information, but if you have any of these problems, I want you to see your physician. Don't just go by the slides. Make sure you see your doctor, because then you can get the whole picture based on what's going on with you specifically. Because I know I could go on for a year talking about the GI tract and disorders of the GI system. These are some really nice, easy online resources. So if you wanted to write these down, nccn.org is this comprehensive cancer network. It has a lot of resources for physicians, students, as well as for patients. And there's actually a patient section there. It's free. You can look at screening. If you or a family member or friend have cancer, you can look up information for your cancer there. The asg.org has a patient site as well, and that's will give you more information on endoscopy and colonoscopy, as well as screening. And then cancer.org, the American Cancer Society, they have a website with a lot of patient information as well. So those are just some resources that you can also look at to help you look into things if you're kind of deciding about colonoscopy or not, and can help you decide. So, okay, well, I guess I'll open it up to questions.
All right, Dr. Lynch, is it okay if we take a quick 5-minute intermission?
Yeah, absolutely, absolutely.
All right, thank you. And during the break, there's going to be a pop-up window that's going to appear on the attendee's screen. Okay. That's just going to collect some basic audience information.
Okay.
So we ask for them to complete that poll. And again, we'll do the Q&A after the 5-minute break. So please submit any questions that you guys have to Dr. Lynch, and we'll see you in 5 minutes.
Thanks.
Oops, that was my timer. So we're going to resume the session, and we're going to jump right into the Q&A.
Okay.
Dr. Lynch, how do you want me to do this? Can you see the
I think I can see them. So the first question I see is, are there any new treatments for persons that have C. diff? There's not a lot brand new, but the newer treatments there's a newer antibiotic that they use to treat severe C. diff. So the main antibiotic is Flagyl. If you have a mild case and you're not in the hospital, if you're in the hospital, they'll usually give you vancomycin, and you can also get that as an outpatient orally as well. But they have another antibiotic, fidaxomicin, that they can use. So they have a little additional antibiotic target coverage. The weird thing about C. diff is that for recurrent C. diff or significant bad C. diff, you can get a stool transplant. And so you can take healthy stool from another person and do essentially a colonoscopy and put the stool in, or you can put a what I call a nose hose, an NG tube, nasogastric tube down, and you could put it down that way, which sounds really interesting. So, but usually you'll put it up your backside. So, so yes, that's kind of one of the more interesting ways to treat C. diff. if you have any other questions about that, I don't think I can hear you, so just type me another question about that. And same goes for every question. So I'll try to answer them. And then if you have further questions, just send me a message on the question form, so I know you still have questions about it and then I didn't answer it fully. And I'll just keep going unless I get other questions. The second question is, are hiatal hernias permanent or do they sometimes go away? They are permanent. A lot of people are actually born with them, and there are different types of hernias of your diaphragm. So the diaphragm muscle is the muscle that separates your chest from your abdomen, and you can have a hole anywhere in your diaphragm. The hiatal hernias, where the hole that is supposed to be there for your esophagus to go through and become your stomach, if that hole is loose, there's no exercise that you can do to tighten that up. I wish there was, but that's not something that will go away. If your hiatal hernia is causing you problems and you have a lot of reflux because of it, the main way to get rid of that hiatal hernia is surgery. To fix a hiatal hernia, if it's a smaller or medium-sized hernia, what you'll usually do is you'll take that hole, and where your diaphragm comes down, we'll take that and we'll cinch it together. So we'll use stitches to really cinch that hole down. And when we do this procedure, we put a special bougie down into your esophagus. So it's actually a special device that we put in the esophagus to make sure the esophagus doesn't get pinched. So it makes the esophagus kind of firm when we close that hiatus. And so we'll close the hiatal hernia, and then we take the stomach and we wrap it around itself. And when we wrap the stomach like that, then you usually that wrap will help it not to go up again. And so that all can help with your reflux. And most people, if they have a hiatal hernia and reflux, if they have the hiatal hernia repair, they generally don't have reflux after that. Okay. The next question I got was, what is the general recommendation regarding the frequency of colonoscopies? So this question is a very hard question. That all depends on so many things. So that question, I'd say I would direct it specifically to the person who does your colonoscopy. So in general, if you are a perfectly average risk healthy person, and you have a great prep, so your colon cleanout was very good, and the proceduralist thinks that they got a good look at your colon and the cleanout was good, and you had 0 polyps, you're generally not going to get a colonoscopy for about 10 years. If you had 1 or 2 extremely friendly hyperplastic polyps that were tiny, you might also not get a colonoscopy for 10 years. However, if you have tubular adenomas, if your cleanout wasn't good, if there were areas that they couldn't see because of the cleanout, if you have a family history of colon cancer, a personal history of other polyps or colon cancer, or if you have even higher risk polyps like sessile serrated adenomas or tubulovillous adenomas, your interval is going to really be dependent on exactly what you looked like inside. I'd say on average, most people who have multiple standard polyps are going to get a colonoscopy in about 3 years. Most people who only have 1 or 2 very small polyps are going to get a colonoscopy somewhere in the range of 5 to 10 years. And then someone who has a really significant predisposition to cancer, you may be getting your colonoscopy less than 3 years. If you have a colon polyp that had to be removed with multiple passes, so you saw that snare, that lassos around, if I have to put a lasso in 3 times just to get rid of the polyp because of its size and it's very concerning or has some precancer in it, I may be doing your colonoscopy in 3 to 6 months to make sure that there's nothing residual there. So that really depends on exactly what you find. So hopefully I answered your question, you know, based on those findings. With the other screening tests, it all depends on that specific screening test. So usually people will do, if you do a fecal occult screening test, just blood test for the testing your stool for blood, that's usually done yearly. And so it really depends on if you have symptoms, if it's truly screening, and then exactly what test you're doing. The next question, this is a very good question too. What age should these procedures not be made? 75, 85 were the question. So if you look at the Society of Gastroenterology, they say that we really should be screening people between the ages of 45 and 75. After 75, we really need to start making this an individualized process. So if I see someone who's 78 years old in my office, they tell me everyone in their family has lived well into their 90s, their mom's over 100 and still alive, and they're extremely healthy, which I have had multiple patients like this, luckily. Their family members are very healthy and they have a history of polyps, and they have many polyps. I'll do that patient's colonoscopy because their life expectancy is over 10 years. If your life expectancy is less than 7 years and you're age 75, it's less beneficial to get a colonoscopy. If you've never had a colonoscopy, that would still probably be of benefit if your life expectancy is maybe about 10 years. Because what if you did have a colon cancer right at that moment and it was early? Then you could still undergo surgery potentially and remove it. Where I would definitely not recommend a screening colonoscopy is if you're 76 years old, your life expectancy is less than a year, and you would be putting yourself at risk for the colonoscopy. So let's say you just had a heart attack 2 months ago. That might not be the right option for you. And in fact, in that exact scenario, I'd say, I think we should hold off on a screening colonoscopy right now. For someone who is extremely healthy, but 85 years old, that's kind of where we really start drawing the line. I'd say after 85, you almost never, I don't want to say never, but you're generally not doing screening procedures after 85. And then from 75 to 85, it's extremely patient dependent. Okay, so the next question is about swallowing. So I am having more and more difficulty swallowing. My mother and grandmother both had this difficulty. Is there some procedure to check on this? Absolutely. So in my picture, I showed you a couple of tests, but there are actually more tests than that. One of them, there was that esophagus that looked really big. It was an x-ray, and the esophagus had white liquid in it. That was barium. That's a barium swallow test. It's also called an upper GI series. There's upper GI endoscopy, where I look down with a scope. That's an EGD, but there's also upper GI series that can be done where you swallow and they watch you swallow with the x-ray machine, and they take x-rays. They actually can see how everything looks from a bird's eye view. And that's really nice. I'm sorry, my son just walked in here. Hey, it's okay. It's okay. Mommy's giving a presentation. I'm sorry. And so that's a good test to really look at your anatomy, so that you can see where, if anywhere, if you have some narrowing. So usually, I'm sorry. So usually, I'm sorry about that. I think he's mad because I'm doing a presentation. I'm not out there with him. That's okay. But usually if you have a narrow spot in your esophagus, that can cause you trouble swallowing. The other thing that can cause you swallowing issues is if your muscle isn't working well. So on that picture of achalasia, that muscle was really tight at the bottom. There are multiple other disorders that are in that similar category where you can have problems moving things down with the peristalsis, or be narrowed or tight in other areas. And so you may also need a pressure study, which is called manometry. A manometry study, they actually go in and they measure the pressure of your esophagus all throughout it. So up here, middle, lower, they make sure your sphincter relaxes. So I'd say for anyone who has trouble swallowing, you want to get an EGD, an upper GI study where you drink the contrast, and then based on those, potentially a manometry study where you look at the pressure. For some people who are having reflux, those patients may also get a special capsule that is put onto the aspect of your esophagus near the bottom. And so that capsule is put in with the scope and it attaches to your esophagus for about a day. And it measures how many times in a 24-hour period you have reflux and how bad those reflux episodes are. So that's another test that you can further evaluate for. Some people have difficulty swallowing because of reflux. Some people have difficulty swallowing because of a muscular issue. Very rarely you can have difficulty swallowing because of a tumor like a cancer. And you can also get diverticula, like I showed you in the colon. You can also get those in your esophagus as well, and that can cause problems. So there's a lot of issues that can happen with the esophagus. So definitely we would want to do all those studies sequentially in you, okay? Does anyone have any other questions for me?
Hi, Dr. Lynch. It looks like there's 2 questions in the chat right now that aren't in the Q&A.
Oh, okay. Let me look for them.
Looks like it's...
I can pull it up, I think. Oh, yes. Okay. Okay, so is there a specific side a patient is supposed to lay on for a colonoscopy? If so, why? So we generally set the patient up laying on their left side, and that's just how we standard do the colonoscopy. And so all of our equipment is set up to do the colonoscopy on that side. Also, when you're laying on that side, if we need to put some gentle pressure on your abdomen in a certain area, because some people, their colon is very curvy in the sigmoid region that is on the left side, we can gently put some pressure there, or sometimes we'll put a pillow and you'll just kind of lay on that pillow, and that can help the colonoscope guide around your colon easier. Yeah, so everything is just set up, and the way the scope is, it comes in from this direction. It's hooked onto a machine back there. So everything is set up so that it comes in from this direction. So you generally are laying on your left side. I look at the screen in front of me. I have to push the scope in that direction based on where everything's attached to. So that's a good question. What can a patient expect to learn from a GI doctor if they have irritable bowel syndrome or chronic constipation? So this all depends on the reason why you're having the symptoms. I'd say when you get evaluated for a colon problem, you definitely want to let the doctor know, do you have any bleeding at all? Do you have any pain at all? The pain may be in your belly, the pain may be lower down, or it may even be in your anal area. And so you want to let that provider know those. Also, when you go to the bathroom, do you go once a week? Do you go every day? Do you have to take a stool softener every day? Do you take any other products that are, herbal supplements, or do you have to take a laxative like Miralax to go? So I'd say you should be able to give that physician all of that info so that they can really diagnose and treat you based on kind of the whole overall picture. If you have irritable bowel, some people are set off by certain things, some different stressors in life, some foods. There are a lot of things that could set it off. You also probably want to be tested for other things. So for example, if someone came to me with chronic constipation, a change in their bowel habits, I would recommend a colonoscopy. So I'd say you would want to have some diagnostic surveillance just to make sure there's not something else going on. So I'd say the number one thing you'd want to learn from that GI provider is, do I really have just irritable bowel? And I don't want to say just, because it's not fun to have that, but do I have that and constipation, or is it something more life-threatening, or is it something more easily fixed with a different surgery or procedure? So you definitely want to find out how to make sure that there's nothing else that's causing the problem. After that, once they've ruled out other things like allergies as well as doing a colonoscopy and taking samples, then they can tell you, okay, your colon looks good from the naked eye. It looks good on the biopsies. There's no infection there. The stool tests are all negative. And then they can say, okay, here are some diet changes I'd like you to try. Here's a bowel regimen that I'd like you to try. You generally want to talk to the patient about what is going to be healthy for the colon. So I would say, here's where we start clean. We have a healthy, well-balanced diet. We drink a lot of water. Make sure you're getting fiber. I generally recommend a fiber supplement because fiber can really help with both constipation and diarrhea. You just have to find the right amount for you based on the amount of fiber you're eating in your diet. And then you also want to find out from that GI provider, should you be taking a stool softener and or a laxative, and kind of how often or just as needed. So all of those things I'd say you'd want to find out from your doctor. Okay. Are there any other questions? I don't see any more. Let me make sure I'm not missing. You're welcome. I gotta thank you. You're welcome. Hopefully that was informative for everybody.
I don't see any questions. So
Okay.
that will conclude tonight's mini medical school series. Thank you once again, Dr. Lynch, for taking time out of your day to share with us. And thank you to our attendees for joining us and sharing your questions. We hope that you'll join us here again next Tuesday. The mini medical school series will be every Tuesday in March and April from 6:30 to 8:30 via Zoom. And our next topic is going to be focusing on wellness and the mind-body connection. Once again, before we end this meeting, I'm going to ask you to fill out the survey questions that are going to appear on your screens if you haven't done so already. Your feedback is anonymous and it will be used to help us plan out more mini medical school sessions. Thank you and have a wonderful rest of your night.
Okay, thanks everyone. Thanks, Brett. Bye.
Thank you, Dr. Lynch. Bye.